and just getting a grip there, and you can see it is quite loose. The patient had been using drops. In fact, I would say the patient had overused drops in this ear, and you'll see why in a moment. When we remove this plug of dead skin, the eardrum will be revealed, and you'll see the eardrum itself will be quite wrinkled. So when you use drops excessively, and you've got especially hydrogen peroxide drops, which is water-based, it has a wrinkling effect. So it's almost like when you go for a shower and you get all this dead wrinkly skin on your fingers, and it's a similar effect on that patient's eardrum. Nonetheless, that will dry up now. Quickly on to patient 2. The patient attended with, I think bilateral, I think this is a patient with both ears. We performed the procedure in. A lot of soft wax there, removed a huge plug right at the entrance. When we, the medical term for wax that's located near the entrance is lateral, and conversely, if the wax is deeper in the ear, that's medial. You can also tell that we're at the entrance of the ear because you can see all the cilia, the patient's hairs on the ear. The cilia are always located in the outer third of the ear canal. That's where all the hair follicles are found. The inner 2/3, when it's just a very thin layer of skin coating the bony part of the ear canal, there shouldn't really be any hair follicles there. Managed to remove that. You can see the eardrum's nice and healthy, got a good light reflex there. The patient's ear canal is quite inclined. Everyone's, as adults, all of our ear canals do go upwards, like a gentle slope upwards. This patient, I would say, it's a bit more pronounced. In children, it's the opposite. Up to the age of 3 or 4, the ear canal actually goes downwards. It's a slope down, so it declines. And as the child ages, the ear canal will change shape, and not only would it get slightly longer and wider in diameter, but it will also then become more inclined like this patient's. You can see lovely healthy eardrum. Same patient, just the opposite ear. Again, you can see the patient's been using a lot of drops as well. Wax is quite wet, soft. Just using a Zola suction probe. There's a bit of dead keratin there on the anterior canal walls. When we say anterior, we mean to the front part of the ear canal. This plug is a bit more medially located. Managed to extract that. Again, so we're just getting the endoscope past the cilia, so past the hairs at the entrance, so we can visualise what we're doing. Quite a lot of time we get comments, why don't we trim the cilia? They serve a purpose. The cilia help the secretions from the sebaceous and cerebrous glands come up from deep within the ear canal itself to the surface. So the sebaceous glands and cerebrous glands are attached to the cilia. If we start cutting the cilia, then these glands, the secretions from the glands won't come to the surface effectively. You can also risk folliculitis, which is an infection of the hair follicles. So the cilia do serve a purpose. Only very occasionally do I have to remove them when I literally can't see a thing, and I actually pluck them using crocodile forceps. Just going on to client 3. So this client's ear canal is slightly more narrow at the entrance, it's slightly more slit. And again, the patient has been using drops prior to attending. There's a lot of dead skin here that's attached to the wax, but also attached to the ear canal wall. So what we're trying to do is loosen this dead keratin and wax plug, and you can see the technique I use there. I get a suction grip and I gently wriggle in little circles just so it loosens off the canal walls. Got the outer lateral plug of wax out. There's an inner, more medial, deeper plug. This wax is a bit darker, and when the wax is a bit darker in colour, it means it's oxidised, so it's been in there longer. You can compare it to an apple or an avocado. As soon as you cut into the apple, you expose the main flesh body of the apple to the oxygen. It will oxidise and turn into a black colour. So again, just gently wriggling this wax out of the ear. Just a bit of wax that got dislodged, got trapped at the entrance as I was pulling through the larger plug. So I'm just mopping up around the edge. And you can see the eardrum in the distance. This patient's ear canal is quite straight. Not the first and second bone were not really prominent, but there was quite a prominent inferior recess. So about half a centimetre away from the eardrum, we have a natural narrowing called the isthmus, and then the ear canal, protrudes outwards again, and that causes and creates trenches near the eardrum, and you get a trench called the inferior recess, which is almost like a trench at the base of the ear canal, and that patient had quite a prominent one, and people with a very significant and enlarged inferior recess are always at risk of getting water trapped in their ear. So when they go for a shower, which you should avoid water trying to get in your ears if at all possible. People with an inferior recess, the water can sometimes get trapped in there and it's very hard to drain. Same patient, just the opposite ear. Again, the patient's got some plug of wax attached to some keratin there. You can see the keratin, you can see at the bottom there when I'm wriggling the wax. I'm just trying to detach that. Dead keratin acts as double-sided sticky tape. Not only does it stick to the ear canal wall, but it can also stick to the earwax. Sometimes can be very hard to remove, very stubborn and adhered keratin. Again, just gently wriggling this plug of wax out. So you know we're near the entrance now because you can see the cilia. The ear canal entrance does narrow a bit, so this plug, I believe, gets slightly stuck. It's a bit softer, this earwax. And we're just gently teasing it out of the ear. There we are. So there's the eardrum that's visible, looks healthy. Again, slightly wrinkled, probably a bit too much drops in there. And especially the water-based drops, it has this wrinkling effect. So the eardrum, the membrane, the outer membrane of the eardrum is also a layer of keratin, dead skin. And again, as I mentioned at the beginning of the video, when you go for a shower and it's all that steam, it can get the outer layer, the epithelial cells of your fingertips all wrinkly. They somewhat get dehydrated and they become wrinkly, and it's similar with the eardrum as well. Bit of keratin here on this anterior canal wall. I don't think I removed all of this. It's just that there's a bit here that came off easily, so I'm just using a fine end gouge. A fine end gouge is the best instrument to remove dead skin because it doesn't clarinet. If you use, and I've left it at that, I think, there's a bit at the top that I just tried to mop up, but there's no need to remove the rest. And it was clarinetting. So clarinetting is when the skin viciously and violently vibrates, gets a tip of the suction probe, and it emits a very, very loud, almost deafening squeal. Sometimes you get it, sometimes you don't. I think with this patient, it was squealing quite, it was quite loud, and it's deafening for me as the audiologist performing the procedure, so we just leave that. That's all the remnants, all the extractions of the ear on a tissue. I think this is the last patient. Again, patient's got a plug of soft dead, I would say again, it's earwax, but also a lot of dead skin here. They had been using a Q-tip, so they pushed it really deep into the ear canal. Also been using drops once again, which is of course the waxed and dead skin plug to be quite wet and soggy. Nonetheless, managed to get a suction grip and vacuum it all out. At first, actually, I thought that was a bit of a Q-tip. A Q-tip can have that kind of texture and colour, but it wasn't. There's the eardrum again, it's wrinkled. So it's the cases of the wrinkled eardrums in this particular compilation through excessive use of drops. I hope you enjoyed that compilation, guys. If you're watching for the first time, please do subscribe to my YouTube channel. There's a